So again, welcome to today's program. This is the Arizona Telemedicine Program, the Connected Health webinar series. So we'll just go ahead and move forward here. We respectfully acknowledge the University of Arizona is on the land and territories of Indigenous peoples, and today Arizona is home to 22 federally recognized tribes, with Tucson being home to the O'odham and the Yaqui. The Southwest Telehealth Resource Center represents Colorado, Arizona, New Mexico, Nevada, and the Four Corners region, with a combined total of 72 recognized tribes. Committed to diversity and inclusion, the university strives to build sustainable relationships with sovereign native nations and Indigenous communities through education offerings, partnerships, and community service. All right, so welcome everybody. As you joined, your phone or your computer microphone were muted. Please use the chat function. Drs. York and Klotz love getting all of your questions in our chat feature, so please go ahead and type them in there. I do have a post-webinar evaluation. For our physicians, we have CME credit, which is available during the live presentation. There's a code in the evaluation and you can log in with that code. All of our EMS folks, again, welcome. I will be sending out my thank you email with that evaluation link. And for our groups that have that are utilizing your conference rooms, you can give me the list of names of everybody that are joining me today. So this was sent out in previous email as well. And then also when you registered here, the outcome objectives that we're going to go over today, and the accreditation statements and financial relationship statements for the CMEs. We have our standard disclaimer. And those of you that have been with us before know how entertaining this program and series is. So please be sure to check our website for upcoming webinars. We do have another one in this series scheduled in March 12th, I believe it's
13th.
I believe it's the 12th. I believe it's the 12th, Wednesday the 12th. And that was in my initial email to everybody, letting you know that we already have 2 scheduled this year. So please go ahead and register for that. And again, that information will be in my thank you email when you're done. So this is just a little more information on that. Again, this is the Arizona Telemedicine Program, the Southwest Telehealth Resource Center. And here we have our illustrious presenters, Drs. Klotz and Dr. York. Dr. York, would you like to go ahead and continue on from here?
So let's get to our opening slides. All right, so we're back. We're leaner, we're meaner. We've got some new topics put up for you. At least I'm leaner. I think Dr. Klotz is a bit meaner. But we're going to do some monthly 1-hour lectures, same format that we've always done. Same, we'll have CME provided. Target audience. This year, we really wanted to retool things, orient it specifically to our core group of folks who've been loyal this whole time. You've given us these awesome suggestions. A ton of our topics last year were not things that we had planned for, and you all recommended things that ended up being, I think, some of our best talks that we've done. So for you folks, we're going to have some things that are catered a bit more to you than we've done in the past. We may leave our Southwest theme a little bit behind, but hopefully we'll have something fun and exciting for you.
What's in that write-up or photograph?
We're setting up your topic there a little bit for just a tease. I can't give it away just yet. All right, let's do the next one. So at least for now, these are some of the topics that we've got on board for you all the way up to December of next year. Again, if there's anything you want to see that you don't see on this list, by all means, make sure you put it in your eval that you do. We do look at those. But probably next month, I think, is coccidioides. Are you going to do the citiobolus, you think?
Yes.
All right, so those top 2 will be our presentation topics next month. But in the meantime, let me turn it over to Dr. Klotz, who's going to get us started with a fun and peculiar infection.
Okay.
Hold on one second.
Our director is getting this all set up here. Thanks a lot for attending today, everybody. This is our first in the series this year calendar. Okay, so let me see if I've got this right. So today, I'm just going to have a discussion and show a few photographs and talk a little bit about some skin lesions you may run across in your work, in the emergency room, or just out in the field with ENT. And of course, this is all within our series of webinars the last several years. All right, so the first is differentiating skin eschars and bulli. Eschar is nothing more than dead skin. necrotic skin that heals like a leathery layer. And in the upper left-hand corner, you see a picture of such a lesion, which is surrounded with a lot of edema. And this is one from cutaneous anthrax. It causes really large lesions in the skin if untreated, and has about 20% mortality if patients are treated. The next one over to the right has a central eschar, as you can see there. And these are lesions I've seen quite frequently in patients who've returned from sub-Saharan Africa, South Africa, particularly where they've been on safaris. And this is the lesion from a tick bite, a hard-bodied tick, and it's known as Rickettsia africae. Very common, disappears almost within days, with months when you begin using doxycycline. And the next one over is cat scratch disease. It too has a central eschar or scab on it. It's very fleeting. You don't see it on all cat scratch lesions. The one to the far right, with a punch biopsy right in the center of it, is a former ulcer from ulceral glandular tularemia, which we've talked about several months ago. So these are all zoonotic diseases. They normally are transmitted from animal to animal, and it's particular with each animal. And knowing which animal is which, associated with which problem, is very important in your differential if you encounter patients with these skin lesions. So they've come in contact with the pathogen involved with these skin lesions. And tularemia is also differentiated by the fact that it always has a very tender, enlarged regional lymphadenopathy. So if it's on the forearm, under the axilla, it's going to be really tender and really swollen. And they'll have this ulcerative lesion on the skin. And if it's ORF, which we're going to talk about in a moment, this is really a grim looking thing, but it's absolutely harmless. And it has a painless bullous. This is the main lesion. Cat scratch disease, which probably you've looked up in the past. There's really no good therapy, but it's only a fleeting eschar, and then it's gone. And the tick-borne rickettsia, like R. africae that I talked about, or starry, southern tick-associated rash and infection, pathogens unknown. Body rash occurs after the bite, and it's all due to a Amblyomma americanum tick, which is a hard-bodied tick. And Rocky Mountain spotted fever, which is endemic to certain tribal areas and counties in Arizona and has been since about the early 2000s. So beware of that, although actually the eschar is rarely seen with this disease. And anthrax, which gives rise to these bullous lesions and a lot of edema around them in the cutaneous form. And if you scratch that scab or eschar up and reach underneath and take a cotton swab and put it, you can grow this microorganism, and you can see it on gram stain because it's gram-positive bacilli in boxcar shapes, one after the other in the tissue. Okay, so let's start with ORF, O-R-F, strange word, relates to sheep. A zoonosis of sheep and goats and camels, if they're in the right region of the world. It's more terrifying looking than any problems it really causes because it heals without scarring at all. And rarely anyone has fever, or they may have an erythema multiforme sort of allergic reaction several weeks into their skin lesion. And, you know, it won't go.
There we go.
Okay, that's the typical skin lesion right there. It's targeted. And they're often quite large. I've seen them as large as 3 inches across in diameter. But they're typical because they have this red rim around it, and then they have a bullous lesion, which is usually white and fluid filled. which can break open on its own, and it has here and formed a little eschar on the top of it. And there was an interesting paper I read in 2012 in the Morbidity and Mortality Weekly. And this was describing 4 people, and this is the way we're going to see this in the United States anymore, amongst a few agricultural people, but more people who aren't accustomed to animals like this, but are at home slaughtering them for a ceremony. And this individual got stabbed by bone from a sheep, I think, and got it in the palm of his hand. And they're painless, and they are very large and nasty looking. They're filled with these box or brick-like shaped viruses. They're DNA viruses. They're quite large. You can actually see this on light microscopy. And there's another targetoid lesion on that person's knuckle. This is a parapox virus, so it's not closely related to smallpox, but it is in the family of these DNA viruses. And it's known as ecthyma contagiosum or contagious ecthyma. It's harmless. It's found on the hands, arms, and often the face. It's caused by contact with the animal or a fomite. So if you're working, shearing sheep or cutting things with a tool and then touch the sheep, and then touch your face or arms, you can inoculate this virus into little small microscopic lesions in the skin. As I said, it's confined only to sheep, goats, and camels. Buffalo pox, which is found in India, may be the same virus. But here are some other lesions, and I did quite a bit of HIV work in Ethiopia, where sheep are all over the place. Half the population is Christian, half is Muslim. They both have their ceremonial holidays each year. And they all, I think every individual in Ethiopia must have slaughtered sheep in their backyard. And one of the problems of just going around, the only travel device we had to travel in was a little jitney bus, seat about 8 or 12. And people would get on with this sheepskin in a plastic bag. And I mean, the odor was just incredible. But I used to see these skin lesions in Ethiopia a lot. The one on the upper one, you can see it looks angry. It looks like it's inflamed. You see the blood within the blister. The blister down below looks like it might hurt as well, but it doesn't. And I wanted to mention, the reason I brought this all up is because Passover is April 12th, not too long from now. Easter, April 20, and Eid, June 25th, 25. So in preparations for these dates, people are going to be slaughtering these animals at home, and they do in Arizona, and expect to see this perhaps if you're lucky. So resolution is spontaneous, but people have used imimod, which we've used for genital warts, and molluscum contagiosum, which is a related virus to this. It's there's a week's incubation, self-heals in 6 to 8 weeks. Don't fool with the skin lesion, don't break it open. And the only problem that can occur is a secondary bacterial infection, which might be treated. Last time I ran into it in Arizona was in 2005 here at the University Hospital. And a wildlife management postgraduate student came in, and he had these incredible lesions all over his hands and his side of his cheek. And he had been capturing bighorn sheep up in the Silverbill Mountains, a little bit north and west of Tucson. And he would jump on them and sort of wrestle them to the ground because he knew already that they had orf. So he had a plastic garment on and gloves and everything, but he still got infected. And I had no idea what his problem was. I thought he was going to die right in front of me. He said, "Oh, no, this is orph." And I thought, oh, I just wrote 3 books on this problem. But I never thought of bighorn sheep. And you can see that ram, it's got lesions all over the tongue and the lips. And it gets in the eye and they can end up having a severe keratitis and lose their sight. So next thing I want to talk about is anthrax. And anthrax is caused by a bacterium known as Bacillus anthracis. It's one of 30 or so bacillus species that are found on the Earth's crust. They're very important because they're recycling carbon and nitrogen, this bacteria. And there are over 30 species, as I said, and one of them you probably have heard about on rounds or something in patients, Bacillus thuringiensis, which is one that is commonly found in insects. And the toxin from that particular bacillus is genetically engineered into plants, poisons insects that try and eat them. It's called Bt toxin. But Bacillus anthracis possesses 2 circular DNA plasmids, which are required for the pathogenicity. So it's just a bacillus species, most of which are totally harmless. This one has 2 plasmids, which create all the problem. And the last time I ran into this, and then I started writing book chapters about it and growing it in the lab, not anthrax, but one that were missing these plasmids. And here's a photograph of Fort Smith, Kansas ranch. And you can see these dark cattle walking around. And then you see all these cattle who've had their hides stripped off. And look closely, you'll see that it's all blood dripping down the sides of their flanks. And if you look in their mouth, no, it's just blood gushing out their tongue and everything. This is characteristic of what happens when ungulates die of anthrax. They have uncontrolled bleeding. And their anthrax bacillus is so thick in it, it's unbelievable. The minute it is exposed to oxygen, the bacillus turns into a spore. And that spore can sit there for 100 years, only inoculate someone else, a cow in the same farm in 1990. And this particular bacterium is spread throughout, particularly in the Midwest and up into Canada. Every year, Canada has outbreaks of anthrax amongst Slave Lake buffalo. So I had a lot of interest in this particular thing, and I'm bringing it up today because it has that lesion that we saw in the very beginning of this presentation. So it has these 2 plasmids, one of which is for a capsule, and the other is a toxin. So here's the way the lesions start. This was a picture of a young man in, I think it was Tanzania, who he was a herder and got it. It all starts as a papule and then expands over time. And there were thousands of people who contracted anthrax in Eastern Africa during the 1990s. And it was all uniformly kind of in patients or individuals who were herdsmen of cattle. Here's a picture of a child in 2001 in DC who was a recipient or had somehow his father had opened the letter from the terrorist activity during that year and got spores inoculated in the arm. And you can see this big leathery eschar on the arm. And this was anthrax. So, as I said, I grew it in the lab, and you can see the 3 parts in which it circulates, or you can, are the 3 morphologies. One is a spore, which is a long-lived microorganism. And as I mentioned, it can remain viable for over 100 years. Excuse me a minute. How am I doing there?
You're doing well.
Okay, giving you time. And then you have the bacillus, which is two. It's characteristic because it's shaped like a boxcar, one after the other, gram-positive. Then three, you see spores being formed in those bacilli after they're exposed to oxygen, like those cattle will have bacilli all over, but they're going to immediately start making spores, which contaminate the ground. So this used to be a big problem in the United States, particularly on the eastern seaboard, where we had textile mills. People were working with wool, and they were known as wool sorters disease, where they would inhale these spores and end up with a pneumonitis, which eventually ended up either with a hemorrhagic meningitis or the patient just dying from sepsis. Well, we've learned to treat people with this with aminoglycosides. But actually, every Bacillus anthracis strain I know of is sensitive to penicillin G. So, and when to think about anthrax? Well, it's the employment history of the patient in front of you, whether they're a herdsman, a veterinarian, a textile worker, hide and wool worker. And the chest X-ray findings of the pneumonia are widened mediastinum. It's very characteristic and typical board question. And the cutaneous lesions are this necrotizing ulcer with a bullous, lots of edema, and bacteria present beneath the lesion. That's how you diagnose it. Cutaneous form. In hemorrhagic meningitis, you see the cerebral spinal fluid is filled with this gram-positive bacilli. Okay, one other skin-causing or lesion-causing, heck with it. Tularemia. We've talked about it before, and as you know, there's several modes of acquisition, just like there is with anthrax. But it can be hunting animals like rabbits here in the United States, or hare in Europe, or sitting on top of a beaver mound or lodge associated with tularemia pneumonia. The most common vector of tularemia in the eastern United States up to Mississippi really is the ixoda tick, as you see there in the upper left. And here in the west, it's the bite of the deer fly, which entirely different vectors, and you need to know that. We discussed that several months ago. Now we have now a new arrival amongst the pox family, which is monkeypox, which is actually in the same family as smallpox. It's an orthopox virus. And in 1922, we had a big outbreak amongst mainly gay men. And this is an unusual presentation because normally in the wild, monkeypox doesn't get transmitted from human to human, but all the close contact, et cetera, and lesions involved led to this outbreak of probably hundreds, if not thousands, of young men or men with monkeypox. You can see some of the characteristic lesions. They actually have some of them with the Neshar on them. And they can be more extensive than that, and also they're subject to secondary bacterial infection. The interesting thing is this vaccine, which is very effective, is a derivative from vaccinia, which was cow derived by Jenner back in the late 1700s. Same origin. Okay, and how it happened, we'd had outbreaks before in the United States, but they were mainly monkeys brought to areas in the United States like Texas. They were housed in the same room in preparation for sale in pet shops with prairie dogs. And then the prairie dogs ended up with it. They got sold to people. And the next thing you know, you had people out in the Midwest with monkeypox. What's their contact? But that was the story. So now I've got a question for you and we'll end it. This is a 28-year-old man, looks like a child's arm, but it's a 28-year-old man with multiple skin lesions. You can see an eschar in the center of this one on the right. And what's also evident is this is really edematous, this form, right? Fingers, and you see another eschar there on the right fourth finger. And then I guess it's his left arm, there's multiple lesions on the skin. Laboratory examination revealed white blood cell count with mild elevation. The left shift, C-reactive protein was really high. Aspiration of the material was obtained from the lesion on the fourth finger. It was stained with gram stain and cultured. Gram-positive bacilli were seen. This occurred in Turkey, didn't occur in Arizona. What is the disease and what would you treat it with? Anyone here?
And for the folks watching, you can type it in as a question and it'll pop up for us. If you want to play along, we encourage participation.
Well, Larry, will you play along? What's the problem?
And this was in Turkey?
This was in Turkey, but if you saw him walk into the ER today, what would you do?
Well, looking at it, first thing I would worry about would be something like orth. Am I close?
Okay.
I don't remember what the animal
Well, you didn't
was.
even ask him if he had anything to do with animals.
Well, we know that already. He slaughtered a bull, didn't he?
A bull. Does that associate with orth?
No, or are you thinking that this is more anthrax?
What do you think?
Well, we have a gram-positive bacilli. Do I have the option of looking in the microscope?
Sure.
Okay, what do I see?
You see multiple gram-positive bacilli in a boxcard
Oh, there you
configuration,
go.
one after the other, just stacks up.
That sounds like anthrax to me.
It is. And what would you treat them with?
I would do ciprofloxacin. I hate doing aminoglycosides on top of it, but well, let's see. We have a white count.
Well, it's cutaneous, so you're gonna get away with fine just giving them oral ciprofloxacin.
Okay. But this is 10 days, okay. How long has he had the lesions?
About 6 days.
Okay. He waited 6 days to come in with that?
No, you're getting technical.
I'm more for the
I told you it was in
aminoglycoside.
Turkey.
For me, I think
I've been in
aminoglycoside
Turkey for 20
severity.
years.
I think that's for me is the concern is do I need to go extra hard on this guy? Otherwise, I would be happy with ciprofloxacin.
Yeah.
Okay.
Okay. So the point of all of this was just to relate to you some possible skin lesions you might see. They're associated with zoonoses. The time of year in which this could occur, particularly orth, is coming up. And if this were a lesion like this and it didn't have, it was associated with cattle exposure and it didn't have bacilli underneath it, it would be a milker's nodule. It's exactly the same presentation as orth that's only found with cattle. Milkers, it's known as pseudocowpox. So there's a lot of these lesions, but orth's the one we're likely to run into. And of course, anthrax, hopefully you won't ever see it.
I mean, for a while there was a lot of discussion about agent of terrorism. You heard about people freaking out, they open envelopes, there is powder. How often are you really seeing that brought up present day? It seems like it does not come up like it used to.
If anyone uncovers anyone with this, and there was an elderly man and his wife who were traveling around Montana and Dakotas during the summer, and he came down with being ill, blood culture was drawn, there was bacillus anthracis. And they had been amongst buffalo herds and so forth, wild cattle herds. And it was pretty windy, so spores could have blown into his lungs, so to speak, or into his breath. And he was treated and got better. But the thing is, these spores are spread over wherever there's been cattle trails in the Southwest. So Cimarron Trail and so forth. These are alkaline soils that it probably grows by itself just in the soil. Reproduces or becomes active, vegetative. But thank goodness, we haven't seen any terroristic activities with this since 2001, shortly after.
Yeah, it seems like it's been a long time.
Yeah, and Japanese had an outbreak of this, but the fellow used a stern strain of anthrax, which is the animal vaccine, which doesn't have one of the plasmids.
Oh.
So it's totally harmless. Everyone was breathing in these bacilli. So even these clever little monsters who want to kill us don't know what they're doing.
All right, any questions from the crowd? If not, we'll get them all at the end if you can think of anything. Let's do it, let's switch over. All right, so for our next one, we're gonna deviate a little bit. We've got a few topics this year. Let's see. Or to my sentence. No, just the one I sent you last night. We're gonna deviate a little bit. We're gonna talk about some things that I think are more relevant directly to you, things that you might be exposed to in the field or may have to contend with. The one we're going to focus on today, I think, was mentioned once by one of you in some of the previous presentations that we had done, but it's looking at HIV exposure and particularly focusing on you as the individual. No, there was one other one. Yeah, you're good. Hopefully attached. I've got it back just in case. It was in the same one with the two opening slides. Hopeful. Yes. Does it show in the other? It's weird, it like bundled it in there. Yeah, that's the one.
Okay.
You're good.
Good, I thought we were gonna.
Just have to make it up as I go.
We could have people mean different things.
All right, let me go ahead and share this.
You're all right. All right, so we're going to focus on today an occupational exposure to HIV, how this could happen. Let's really talk about the risk of this happening. How many times has it happened? And if it does, what can you do about it? That is my favorite clip art I think I've ever used. Quality. All right. So for this, we're going to look at routes of HIV transmission. And again, the risk, particularly for an occupational exposure, which is, I think, something that doesn't come up really very often. We'll look at how acute HIV infection may present just in case you find yourself in this scenario, things we would be looking for that may indicate maybe something did happen. And we'll look at ways that you can reduce the risk of HIV if there is a bona fide exposure. There is something that you can do. So instead of our typical case, there's a number of scenarios where I think a lot of the folks that are here could be exposed. Usually I think we think of a needle stick after maybe giving someone a treatment, an injection, a vaccine. Maybe we go to recap it, which you probably should never do, but accidentally poke yourself. We've had cases where maybe someone is in distress, someone goes to help them, they end up getting stuck by a needle that was on the person that wasn't apparently visible or was easily missed. And of course, just blood splashes. Maybe you have an open wound, something happens in the course of duties, and blood does get into that open wound. So any of these scenarios all apply to what we're about to talk about. Now, PEP or post-exposure prophylaxis, it is simply put a regimen effective against HIV that, just like Plan B, and the analogy is pretty ironclad with this, can help prevent HIV if there is a true exposure. And a lot like Plan B, you have a 72-hour window. So the analogy goes well beyond that, just like Plan B. Sure, you could maybe wait 48, 70 hours. It's probably not going to work as well for you, but there may still be some benefit. The same is true for HIV. The emphasis, if you do worry that you may have been exposed, there's been a needle stick, is starting on PEP as soon as possible. A lot of the limited data that is out there pretty much assumed folks could start within 2 to 4 hours of having these exposures. Now, the regimens are all over the place, and none of these are officially approved. There's likely dozens of things that you can do for folks in terms of post-exposure prophylaxis, but what we use present day is really one of just a few regimens. At best, it's a 1 pill once a day. At worst, for most of our folks, it's maybe 2 different pills, one of them being taken twice a day. And again, the emphasis in when we're treating someone for PEP, what we're really trying to do is treat the HIV of the person you were exposed to. And we'll talk about that at the end, why that could matter. So again, looking at occupational PEP, accidental exposures are common in the workplace. I would be curious if you're willing to share how many folks have had a needle stick themselves or have found themselves in a similar sort of situation where there may have been this possible exposure. But the first thing I want to do, at least, to not freak everybody out, what really is the risk of this happening? Well, since the data has really been evaluated, which is about 1981, there have only been 58 ironclad 100% documented cases where a healthcare worker contracted HIV in the course of their duty. And most of those were prior to 1999. Since then, there's only been one case, and that occurred in 2008. And this poor individual was working in a lab with a sample that had HIV and accidentally helped themselves. Now, there's 150 cases that maybe this could have been the real thing, but there were other explanations that may also have accounted for this. And again, the last one of these was actually in 2013. So let's look at the 58 confirmed. 49 of them are from percutaneous punctures or cuts. Very few were from a mucocutaneous exposure. Most of these were probably what you were thinking. They were needle sticks. So let's take it even further and break it down by the occupation and what the person was actually doing. So nurses, if you're joining us and you're a nurse, of course, you're going to be the highest risk. You're probably engaging with these sorts of activities more than anybody. I don't see pharmacists on here, but nowadays that might be. I gotta represent a little bit. I don't fit into this very well. My goodness. All right, so nurses, laboratory technicians, non-surgical physicians. So all of us are at risk, I think, in the occupational healthcare world, less so than I might worry about for what we would call non-occupational exposure. So this could be where the condom breaks, it's a sexual exposure. Risk is probably much higher here, of course, but still the risk is there. So just as a check for yourself, which of these fluids are potentially infectious for HIV? I think most folks can probably guess at which ones here could have HIV. But actually looking at the answer, so of course there's a big asterisk here. If you are dealing with saliva, feces, vomitus, urine, of course, if it appears that there's blood in there, then of course there's a risk of HIV transmission potentially being in there. Blood is, of course, going to be our biggest concern overwhelmingly for being a healthcare worker and potentially having these exposures. All right, so other factors to consider. There's a number of things that probably factor into this, but again, if you go looking at the data, it's not great. We really have guesses at how well a lot of this works and what the risks are. So the viral load for the source patient is going to matter. So in the world of HIV, there is this saying, undetectable is untransmittable. If you're suppressed, which everyone should be if they're on medication, you don't sexually transmit HIV to anyone. The risk is zero. But the key word is sexual. Of course, a bloodborne exposure, while the risk is certainly going to be dramatically reduced for somebody on medication, there is still that risk that could take place. Now, were you wearing gloves when you had the needle stick? That could maybe reduce the risk by about 50%, purely just the physical barrier just thinking mechanically how this happens, it does help. There's a little bit of data, a hollow bore versus a solid bore needle may play a little bit into this too. The biggest one, I think, especially for our folks that may work in the ER, we've had questions from surgeons about this. One fellow in particular went to wash his hands after a surgery. There was dry blood on the handle of the sink, and this was the concern. And while it is true, HIV does exist outside of the body, it survives for a while. The ability for it to infect, how long it actually lives, absolutely starts to dry out after about 9 hours. So 9 hours, you're going to see about a 10-fold reduction. Several hours into this, you're going to be essentially almost no risk of potentially getting HIV from some of these leftover spills that could be out there. All right, so things to look at for testing. So whether yourself or whether you manage folks that may be emergency medical personnel, we'll talk about some of the ways to go about this. I know that a lot of HR departments like to manage this, or occupational health. We usually do run into some issues there with, I think, just being current on what you can do. And I will briefly address, it's difficult right now to find these guidelines, but there are 2 separate guidelines out there for PAP. There's occupational and non-occupational. The occupational guidelines are the oldest, worst things I think I have ever seen. I would never recommend taking a look at those. I would actually direct you to the non-occupational, with just a few addendums to the lab recommendations. Absolutely straightforward, very easy to do, and it'll guide you, I think, much more clearly than the occupational one as well. But just briefly looking at this chart here, just emphasizing the time course for HIV. You will not see that viral load start to really pop in an individual's blood until maybe around day 7, 8, or 9 or so. And we don't routinely look for viral loads. We're doing what's called a 4th generation test, which we'll briefly mention on the next slide. But why we look at that is there's then another antigenic component that will briefly pop up during these acute or early infections, and that's the P24 antigen. That is what we're looking at in most screening tests. If you were to go right now and get an HIV test done, give blood for that, this is going to be a component that's looked at, is this P24 antigen. Now, after that, you're going to start to see the IgG develop against HIV. If that is discovered, that is a definitive positive based on the current recommendations.
Larry,
Yes.
could you go back and just maybe point out where's the
Let's do
P24
my
on
mouse.
that graph, and where's the antibody?
I think my mouse is translating okay, but this orange line right here is going to be the P24 antigen. And to answer briefly, then why don't we do viral loads for everybody? It's a cost issue. I think an HIV test may cost you maybe a few bucks here and there, 20, 30 bucks, depending on the site. A viral load, when we've accidentally had one ordered, is about $500. It's insane how much this costs. So we typically reserve these viral loads for more defined cases where there probably was a real exposure, maybe symptoms are present, and we're doing it in tandem with a screening test to make sure we're looking at everything. This green line here is the IgG antibody that we're looking at. And this is also the other thing looked at in this test. And let me get to this slide here and I'll come back. So the 4th generation test is looking for P24 antigen in an antibody. If you're negative, hey, you're out of the woods, unless you are in that very unfortunate window period for that first week or so after an exposure. So if we have a positive, it is going to further differentiate. It should tell you if P24 antigen is positive. I won't discuss HIV-2 today because quite honestly, I don't think any of us are really going to encounter this or even see it. Have you had an HIV-2 case? I don't think I'm going to see it in my lifetime. There are brief differences, but a discussion for another time. We are universally talking about HIV-1 for these circumstances. The only time that we may run into an issue, and for you all to be aware of, is the P24 antigen can be positive and the antibody can be negative. And that's one of 2 things that have happened. Either this is very acute, your body hasn't even had time to develop the antibody, or it's a false positive. And I will tell you the P24 antigen can have a false positive more than you would expect. We've had a couple of unfortunate folks that really freaked out. We had these acute tests. And for whatever reason, the P24 for them over a couple of years would flicker on and off, but never would the antibody convert. Sometimes it may be, I've seen folks with early Hep B infection, maybe cancer, that can trigger that. But there's cases where I genuinely have no idea why this is flickering positive for some folks. Right, and just for you to be on the lookout for, acute retroviral syndrome for a lot of our patients, if they're trying to guess when they think they may have got HIV, the question I usually ask is, can you think of a time you had a really bad flu? That often encapsulates a lot of what is basically a general viral illness. Cervical lymphadenopathy is certainly something to be on the lookout for. While a rash can show up, it can present pretty differently depending on the individual, so it may not be as reliable. Right, so we'll briefly look at some PEP regimens just so you are aware of what you can potentially choose from. And we'll talk a little bit about maybe something that we can do in the world of emergency medicine to better protect ourselves against potentially having some of these exposures. So the key point of PEP is once you start, you're committing to 28 days with one exception that we'll get to in a second, but it is a 4-week course. It's not totally clear where PEP is providing the benefit. The leading theory is that you're surely not getting the HIV integrated into the genome. That's essentially the point of no return. You're likely keeping the virus from being able to replicate and giving the body time to flush it out of wherever it may be at that point. So 28 we know is better than 10 days. 10 days we know is better than 3 days from animal models. The true number, who knows? But as we do this present day, 28 days is the recommendation. Right, so the new kid on the block is Biktarvy. So you may even have seen commercials on this for TV. It is honestly the most popular regimen for folks with HIV. It's fantastic, it's powerful, it's easy to take. And in terms of side effects, there's almost nothing I'm really going to worry about, certainly nothing serious, especially for these short courses we're doing for PEP. Now, what you're most likely to see until I think things change a little bit is Truvada or its generic equivalent with dolutegravir or Tivicay, which is the brand name. So this is 2 pills taken once a day to help protect yourself. Basically, this is Biktarvy. Very little difference here, especially for the short course. Other one that you might have seen is Truvada Icentris. I won't talk a lot about this one. It has been a long time since we've had someone come on this regimen or that we've recommended it. It is not quite as potent against HIV resistance as we would like compared to the other regimens, and it is a twice-a-day regimen with the raltegravir. So just briefly looking at the drugs, emtricitabine, you would have to try real hard to overdose on this drug and have a meaningful side effect from it. It is extremely safe to address concerns about side effects from HIV medication. And why I would urge that if you yourself have had a needle stick, I leave it to you. The odds truthfully are very low, but given the circumstances, if you're on the fence about doing PEP, don't let the side effects from the regimens be something that holds you back. These are very safe. I would feel comfortable giving this to elderly family members if, God forbid, there was an exposure. So certainly for you, don't let that be a barrier. Now, tenofovir has 2 different versions. We have historically used the older one, which is this disoproxyl salt. The main concerns there have to do with renal toxicity, bone mineral toxicity. And yes, while it is possible that this could happen very acutely, I would say overwhelmingly the data of concern is in folks taking this for HIV who have been on it for years, that have these faster declines to decreased renal function, decreased bone mineral density. Now, both of these medications do have renal adjustments. Not something I'm going to worry about in the heat of the moment. And quite honestly, it has been very rare that we have had a post-exposure individual come seek care who did have chronic kidney disease that needed to do something a little bit different. We'll address it at the end, but if you do have a circumstance where someone's creatinine clearance or renal function is below 30, that's where I would consult an expert. The regimens, now they might get unpleasant and weird. Integrase inhibitors, this makes up our Biktarvy. This is what makes Biktarvy what it is. Dolutegravir, raltegravir, again, super well tolerated. The worst I worry about with any of these medications is maybe some upset stomach, maybe some bloating. Very rarely someone will say they get headaches, maybe a little bit of dizziness, but usually that all goes away within usually the first few days, certainly after a week or two. These we don't really worry about in terms of renal adjustments, and truthfully, liver disease, you would have to come in with decompensated cirrhosis for me to start worrying about how these medications might affect you. Interactions, not much that I worry about. To nobody's surprise, the usual drugs that are going to cause problems with everything will also cause problems here. These I would also check with an expert. There are some things you can do to help overcome this. I'm not even going to give this final bullet point the time of day. We don't talk about St. John's wort here. If you're doing it, stop doing it. I know you all know better. All right, so some considerations and lab testing. Now, the thing that is easy to overlook, which truthfully is also rare in this country, less than 1% of folks walking around have this, but chronic hepatitis B infection. Now, presumably, if you're a healthcare worker, you probably will know your status for hepatitis B. Certainly, proof of vaccine is something that I'm sure you would have to demonstrate to get the job you're currently in. But at any rate, we always check this at baseline because stopping these medications after the end of PEP can cause a flare in an individual that has Hep B. They do double duty and cover hepatitis B. If the source individual it has HIV and we know they have resistance, which has come up in our clinic, you may do an entirely different regimen altogether. Remember, the idea is to treat the HIV of the individual you were exposed to. If we know they have resistance and these meds aren't going to work for them, they're likely not going to work for you. So again, consult an expert. And I do have a slide here at the end that if you're in a pinch, there's a number you can call to get some advice.
Is it yours?
I did hesitate to put our clinic, but no, it is not mine.
Oh, well, that's unfortunate. Actually, Larry's unbelievable about, answering this.
I'm glad you said requests. I notoriously do not answer numbers that I don't
I
know.
mean, if you're not.
Send me an email if you're worried. I will respond to that.
Well, and he could help you think this through in a sensible way too.
I think that's the biggest issue with PEP, is that it's a very simple thing that people overthink. If you're worried about an exposure, start the meds, we'll figure the rest out later. The key thing is timing, getting it started, and always stop or sort it out a little bit later. Speaking of which, if we are able to test the source individual, if they're negative, then of course, we don't need to continue on meds. But that is the only thing that would lead someone to preemptively stop HIV post-exposure prophylaxis. I wouldn't go testing yourself until you have finished your 4 weeks. There's the median time to positivity is around day 18 to 25. That's the worry, is even though we have what should happen, that's not always what does happen. So labs at baseline, I think pretty straightforward. HIV test, CMP, just to make sure we're not doing anything to the kidneys or liver, and your B and C antibodies. Now, this is what I was mentioning. This is pulled from the non-occupational guidelines, but they have a very nice table that in really 1 to 2 slides, I've got footnotes on the next one, will summarize exactly what is to be done for these individuals. The only difference here is that they include other STI tests, presumably because this could be a sexual exposure. All right, so counseling at each visit, just make sure to use condoms if you are sexually active. The worry is that if, God forbid, you were to acquire HIV, that acute window is the highest risk of transmission. So we always recommend using condoms, avoiding blood tissue donations, pregnancy, breastfeeding. Pregnancy and lactation, I would say that PEP is very safe. All of these regimens actually do have data for pregnant folks with HIV. I would not feel any worries about starting someone on them. Breastfeeding, admittedly, the data is very poor. It does get secreted in the breast milk. You might, on some occasions, see effects in the infant. Sometimes they may be a bit lethargic from, let's say, integrase inhibitors. But overall is felt to be safe and probably worth the risk if you are insistent on breastfeeding and would need post-exposure prophylaxis. All right, so the last thing I want to say is that there are studies for essentially a pill-in-pocket method for PEP. whereby maybe you've got it in your ambulance, maybe it's somewhere in the ER. You have ready to go PEP kits, where if you have a needle stick, you could just go grab it and essentially self-administer PEP and get the ball rolling. We'd of course want you still to follow up either with our clinic or with someone that could just follow you for that course. But I don't think this is the worst idea, just as a prevention method to have on hand. Admittedly, it's somewhat difficult to get these meds, and you may feel that the risk is not there. Again, 58 documented cases in 30 plus years. So take that what you will for that. All right, this is the line that I was talking about. This is the Clinician Consultation Center. They will get you answers, especially for your unusual scenario. So maybe someone with resistance, anything that you may encounter. If you do need a quick reference, this is a universal one that can be used. Now I see a huge question. Let's see what we got. Okay, so relating to HIV detectability, all the messaging on TV reassures folks that they can be undetectable and therefore go out and have presumably maybe a higher risk sexual lifestyle interactions without fear of spreading HIV. Living in family of non-clinical. So that is a good point. So this individual is referring to state laws are different all across the country relating to HIV criminalization laws, exposures, disclosure laws, and that do double check. Some states are profoundly more intense in terms of their laws and guidelines than others are. So to briefly address in general, this undetectable equals untransmittable. I'll be honest, for years, everyone suspected that this probably was the case. At a bare minimum, we all suspected it certainly reduces the risk to something that's probably so low, almost negligible concern. What was done, if you want to look into it, they were called the Partner and the Partner 2 studies. And they looked at thousands and thousands of sexual acts with serodiscordant couples, so one positive, one negative. Condoms weren't used. Admittedly, about 6 people did get HIV in those studies, but they were able to link it to they either went outside the relationship and the exposure was from someone else, or the partner may have been off of meds or had an issue where they did have an elevated viral load. So to answer this U equals U question, I would say I am now at the point, I would say 100%, if you are undetectable for about 6 months at least, I would add in a time component. Undetectable for at least 6 months, I think your risk of sexually transmitting HIV is 0%. Now, the big thing we're dealing with now is breastfeeding. While that is very low, it's not 0. And that is data that we do have. It's a percent of a percent of a percent. But there is still a risk that even undetectable, been on meds for years, if you're breastfeeding, you could potentially transmit HIV. And that's a whole other discussion.
It's sort of interesting, Larry, that there's something unique about HIV and its lack of infectiousness, meaning, people who even get transfused with HIV positive blood,
May not get
only about a third of them don't get infected.
One, I think you're seeing that too in like the number of documented cases. I don't have that hard time believing that number. We've had serodiscordant couples where someone's probably had HIV for years and the partner, despite unprotected sexual encounters, never got it. It is harder than people, I think, realize to actually get HIV. The viral load is certainly a risk factor. There's a number of things that skew into it. But just to briefly wrap this up, we've got about a minute left. I think that was the one question we had. Certainly something to consider. I leave it entirely to your preference. I've honestly worked with individuals that had exposures where even I've said, can't say I'm not worried about HIV exposure, but knowing that it's a tool that's available to you if ever you want to follow that. I hate to be playing armchair quarterback and you got HIV and we say, well, we could have done something and we didn't do anything about it.
All right, if we don't have any other questions, and for our online audience, we actually do have a few folks here in the room with us, sitting around the perimeter of the room. So it's been very engaging having an in-person event as well as our online event. And please remember to do the evaluation that's going to pop up once we close here. And I'll be sending out a thank you email to everybody that joined us. And with all that information on the evaluations and requesting your certificates. So it's 1 o'clock. Thank you again for joining us and welcome to 2025 series. And we will see you again next month. Take care, everyone.
Thank you, Melanie.